Okay, so first of all, I want to thank the organizers for allowing us to present our findings. I'm excited to talk a little bit more about our systematic review and meta-analysis on long-term outcomes following exposure to antenatal corticosteroids. So for today's presentation, I'll be just going over the main sections of our research paper. So that's the introduction, objective, methods, results, and discussion. So as a brief introduction, antenatal corticosteroids, or ACS for short, are commonly administered to women at risk of preterm birth. It helps reduces the risk of morbidity and mortality associated with preterm birth. The most recent Cochrane systematic review found that the use of ACS significantly reduced the risk of neonatal death, as well as respiratory distress syndrome, among other benefits. Despite these short-term benefits, animal studies have shown that doses that are equivalent to those given to humans actually led to adverse neurological effects and long-term concerns for other organs such as the kidneys. Given these long-term harms, we want to better understand the long-term outcomes in children. So the objective of our study were to understand the long-term outcomes in those exposed to a single course of ACS versus those unexposed. And so in this case, a single course of ACS is defined as 24 milligrams of betamethasone or dexamethasone. And secondly, we wanted to understand the long-term outcomes in those exposed to an unspecified number of courses of ACS versus in those unexposed. So moving on to the methods of our study, we searched 6 medical databases from inception until October 29, 2021. Additionally, we searched the first 200 results on Google Scholar. We considered randomized control trials, quasi-RCTs, and observational studies as part of our inclusion criteria. We also included studies with births occurring exclusively in or after the year 2000. We expected older studies to have less clinically relevant perinatal care, and so with this criteria, we hope that we have more clinically relevant studies that are included. In addition, we considered long-term outcomes as those that occurred at or after 1 year of life based on input from a pediatric expert. Our primary outcome was a composite of neurodevelopmental or psychological disorder. We had an extensive list of secondary outcomes, but just to name a few, it included visual and auditory impairment, various psychological disorders, cerebral palsy, measures of neurodevelopmental delay, as well as other outcomes. We extracted data on study characteristics. So for example, on ACS exposure and the comparison group, we extracted data on outcomes and we assessed risk of bias. So we considered the Cochrane risk of bias tool for RCTs and their follow-up studies. And for observational studies, we used a modified Newcastle-Ottawa scale. So with this modified scale, a maximum of 9 stars could be awarded in the existing domains. And finally, we assessed the certainty of evidence using the grade tool. A random effects meta-analysis was performed and effect sizes were reported along with their 95% confidence intervals. And we considered randomized and non-randomized data separately. In addition, adjusted and unadjusted data were analyzed separately, and an emphasis was placed on adjusted data for observational studies to account for potential confounding. For the interest of time, I'll focus primarily on this adjusted data. So moving on to our results, we included 30 studies, all which were cohort studies. 10 of these focused on our first comparison, which was a single course of ACS versus those unexposed. And the remaining 20 were on an unspecified number of courses of ACS versus those unexposed. From these 20 studies, we expect that likely a single course of ACS was administered given the recommended treatment options available in these settings, but just this information just couldn't be verified. So before moving on to the rest of my results, I want to take a moment to explain a convention that'll be used to convey the results. So the red would denote a statistically significant harm, yellow indicates no significant differences, and green indicates a statistically significant benefit. And the direction of the arrow will just indicate if the intervention is increasing or decreasing the effect. So looking at our first comparison of a single course of ACS versus those unexposed, all long-term outcomes from cohort studies were for children born preterm. In children born extremely preterm, so less than 28 weeks of gestation, a single course of ACS was associated with a significant reduction in the odds of neurodevelopmental impairment by 31%, as well as a significant reduction in the odds of cerebral palsy which was one of our secondary outcomes, by 40%. And this is considering low certainty of evidence. In children born preterm, so now less than 37 weeks of gestation, our meta-analysis found no significant differences in secondary outcomes of visual impairment, auditory impairment, or moderate to severe cerebral palsy. And this is considering adjusted data. Moving on to our second comparison of our unspecified number of courses of ACS versus those unexposed, one large Finnish cohort study addressed our primary outcome. The study found that in children born preterm or at term combined, there was an increased risk of any mental or behavioral disorder. And there were no significant differences in children born just preterm. However, the largest increase, which was a 47% increase in risk, was seen in children born at term. In children born preterm, so less than 37 weeks of gestation, our meta-analysis found no significant differences in neurodevelopmental impairment or auditory impairment, which was one of our secondary outcomes. And now in children born late preterm, so this is between 34 and 36 weeks of gestation, we found an increased risk of investigations for neurocognitive disorders by 12% in one of our included studies. When considering children born at term, so greater than or equal to 37 weeks of gestation, two studies reported 45% and 48% of children were actually exposed to ACS preterm and then went on to be born at term. So the studies found an increased risk in psychological developmental disorders, as well as suspected neurocognitive disorders. Moving on to the discussion, in this systematic review of 30 included studies, with low level of certainty, adjusted data suggested that ACS were associated with significant decreases in neurodevelopmental impairment and cerebral palsy for children born extremely preterm, but increased in adverse development for those born late preterm or at term. Now, our study had a couple of strengths that I want to acknowledge. So we comprehensively searched multiple academic literature sources without language restrictions. In addition, we focused on studies with births occurring exclusively at or after the year 2000 in order to have a more clinically relevant pediatric and perinatal context. A limitation of our study was that we had non-randomized data, which can include some degree of bias. We tried to adjust for this or address this by reporting on available adjusted data. And so in conclusion, the long-term benefits that we see in earlier gestations may transition to long-term risk at the late preterm gestational age period. So this may lead us to think about some caution when administering ACS. So if we want more information about our study, it's available in the manuscript that's published in JAMA Pediatrics, and feel free to contact me, and I'll leave my email here as well. But I want to take a moment to acknowledge my supervisor, Dr. Sarah McDonald, for her mentorship, as well as the team that was involved in conducting the study. And finally, thank you all for your attention. At this point, I'll take any questions you may have.